In our last video, we said that normocytic anemias can be due to underproduction or destruction of our red blood cells. In this video, we're going to talk about the destruction of our red blood cells, also known as hemolytic anemia. Now, what causes hemolytic anemias? Well, there can be something intrinsically wrong with the red blood cell. So that red blood cell is made in a malformed way, and it can cause it to have a reduced lifespan or just cause it to lyse or be very fragile in the blood vessel. Or we can have something extrinsic, so something that's not related to blood, that some sort of external source that destroys our red blood cells. There are many ways that our red blood cells can die. They can be in our blood vessels and just lyse apart and then basically break apart, or they can float into our spleen or places like our lymph nodes where macrophages look at it, and if it looks odd or looks funny, then the macrophages will eat it up and recycle it. So when it dies in our blood vessel, we call that intravascular. And when it goes to places like our spleen or our lymph nodes and our macrophages eat it, we call that extravascular because it's outside of the vessel. Either way you cut it, you're going to release a lot of substances that are found in the red blood cells, and you can see that in our blood. So things like increased bilirubin, which puts us at risk for things like bilirubin gallstones. You can have increased LDH. LDH, recall, is lactic dehydrogenase. That's an enzyme found in a lot of cells, particularly red blood cells, that help it make energy. So you're going to have increased these. From our perspective, intravascular versus extravascular, we prefer the extravascular route because in our spleen, our macrophages will be able to eat and neatly digest and recycle these things. In our intravascular route, things aren't that neat. It'll lyse apart and then our stuff will basically fall out into the blood. Things like hemoglobin and iron and things like that. And we'll try and counteract that with a protein called haptoglobin, which does its best to bind important things and recycle it, but haptoglobin is very limited. So I'll write limited. And it won't be able to bind everything. So intravascular is not our preferred method. If you have intravascular hemolysis, then you're going to see things like decreased haptoglobin because it's going to get all used up. You're going to see increased hemoglobinuria, increased hemoglobin in your blood, and also in your urine, so hemoglobinuria. That iron, you can lose it in your urine. That's not good. You can have iron deficiency from that. Our kidneys will try its best to kind of reclaim it. It'll store up into the cells called hemosiderin. So you're going to see hemosiderin. But eventually those cells get overloaded or they start to shed, and you get hemosideruria. Hemosideruria. So hemosiderin in your urine. And that's a little later. So a couple days later. And those are the signs of intravascular hemolysis, just because your cells lyse and basically release everything everywhere. It's not as neat as extravascular hemolysis. Extravascular hemolysis, you don't really see these signs. Now let's see what causes our hemolytic anemias. We'll start with extrinsic. Extrinsic, we said is due to an outside force. So I'll write extrinsic outside force. I can think of one. How about an infection? How about malaria, plasmodium? So our infection, that's an outside source. So plasmodium, aka malaria, or Babsia, which is another parasite that loves red blood cells. So those infected red blood cells basically cause it to lyse or get destroyed. Another cause of extrinsic hemolytic anemia is microangiopathic. Let's break down that name, microangio, meaning small blood vessels, and that's what's causing our hemolytic anemia. This is due to widespread inflammation of our small blood vessels, and when there's widespread inflammation, then these little microthrombi will try and stop the bleeding or stop the inflammation. So you get these microthrombi. And when your red blood cells travel through those small vessels, they hit those microthrombi and basically get torn to shreds. And that's what causes our extrinsic hemolysis. So anything that causes widespread inflammation can cause this. DIC. DIC often follows things like sepsis or septic shock, and basically you get widespread inflammation, that's septic shock. And so your vessels will create these microthrombi and red blood cells will run into it. How about SLE, widespread inflammation? How about things like malignant hypertension? That's just by sheer force breaking your blood vessels, causing those microthrombi. Thrombotic, thrombocytopenic purpura, which we're going to talk about in subsequent videos. Or how about hemolytic uremic syndrome? Now these are all associated and cause microangiopathic anemia. Anytime we have associations, what do we always do? We take a second to think of everything we know. So just pause the video, just think of a few things you know for each and every one of these, if you can. I can start off. SLE, butterfly rash, reduced complement can cause lupus nephritis. HUS, that usually follows things like E. coli. That's the 0157H7 strain, or Shigella. So just pause the video, take a second to kind of recap what you know about these. That's just a good way to recap other blocks into heme, so you're not just constantly focused about heme, you're incorporating other subjects into anything you're studying. So that's microangiopathic, macroangiopathic. Let's decipher the name. Macroangio means big vessels or large vessels, or heart, things to do with your heart, or valves. So a common cause is things like mechanical valves or calcified valves. So aortic stenosis can cause this when there's calcified valves or stenosed valves, and your red blood cells basically ram against that stenosis and break apart. Whatever the case, when you have this shared red blood cells, you see them on peripheral smear, and they are called schistiocytes. Schistio means split, and so you see all these kind of malformed, broken up red blood cells on the peripheral smear. And that's not specific to this. Any kind of sharing forces of red blood cells will cause schistiocytes. Now there's a more complex cause of extrinsic hemolytic anemia, and that is autoimmune. So you make antibodies against your red blood cells. That's the outside force. That's what makes it extrinsic. You're making autoantibodies against your red blood cells. So I'll write autoimmune, antibodies against our own red blood cells. And these antibodies can be IgG, they can be IgM. Another way we commonly classify it is we call IgG warm, because we notice that the antibodies can work at body temperature. IgM, we usually call it cold, because when a person gets cold, they have to go outside and they're exposed to cold, and IgM is seen to work better in a cold temperature, so we call this cold. And these antibodies attack your red blood cells, gather them, agglutinate them. So agglutinate, and that can destroy your red blood cells, or it can go to your spleen, and your spleen sees your red blood cells covered with antibodies and says that's not right, and it'll destroy it then. Now, why you make these antibodies in the first place, not quite known. However, these are associated with a few things. IgG is associated with things like CLL, that's chronic lymphocytic leukemia. SLE, drugs like methyldopa, penicillin. And then recall, anytime we have associations, we take a second, think of everything we know about that association. So CLL, that's your chronic lymphocytic leukemia, seen in older patients, you see that smudge cell. SLE, we've talked about that already. Methyldopa is an antihypertensive drug seen in pregnant women, so they might give you a question about a pregnant woman who has hypertension and is given a drug and develops these autoantibodies. Penicillin, antibiotic, might give you a patient who has an infection, given a drug, develops anemia, normocytic anemia, and then they might ask, what's the cause of it? And you're thinking of IgG autoantibodies. That is IgG. IgM. IgM is a little tricky. IgM, recall, is your acute phase immunoglobulin, so the course is more acute. And also IgM activates complements because it's acute phase, right? So it activates complements. That's just what IgM does, and this IgM is no different. It's associated with things like mycoplasma pneumoniae, so mycoplasma pneumoniae, and EBV. So take a second, think of everything you know about these two. Mycoplasma pneumonia causes pneumonia. EBV, that's the pharyngitis, you have your lymph nodes enlarged. The monospot test, that's the heterophile test. So I'll give you a patient with a history of those two and then ask you if they have normocytic anemia, what happened? They developed IgM autoantibodies. How do we test for these antibodies? We can do something called the Coombs test. Coombs test. Here's the red blood cells, and if you have IgG antibodies against the red blood cells, then you're gonna have IgG stuck all over this stinking red blood cell. Now in the Coombs test, we know this, so in the direct Coombs test, we throw in anti-IgG. And so that anti-IgG will look for the IgG on the red blood cells and attach and cause them to clump, so agglutination. That's a positive test. Now, can we do this for IgM? No, because in IgM, your red blood cell is not covered by IgG, it's covered by IgM, the pentamer. So these anti-IgGs won't attach to it because that's not what they're looking for. So you're gonna have to add anti-IgM, or you're gonna have to add anti-complements because it activates complements, so anti-complements. And then it can look for it and attach. So that's direct Coombs. And indirect Coombs, we add an extra step. In your serum, you're gonna have all those nasty antibodies. So we take your serum, take it out, and then we add someone else's red blood cell. And these will go and attack the red blood cell. Only then do we add our anti-IgG. And then the anti-IgG will go bind and cause agglutination. So it's the exact same thing, as just an extra step. All right, hope you understood that. That's Coombs test. That is autoimmune hemolytic anemia. How would you treat it? Because it's autoimmune, you can do immunosuppressants. You can also give rituximab. Rituximab. Do you recall what rituximab was? Hopefully it says a monoclonal antibody against CD20. That's on your B cells, and you destroy your B cells. Why would you do that? What makes antibodies in the first place? I rest my case. So that finishes our extrinsic hemolytic anemia. Hemolytic anemia is due to an outside force. Now let's move on to our intrinsic. So we said that intrinsic was due to some sort of defect, some sort of intrinsic defect to our red blood cells that make it have a shorter lifespan or make it more fragile in our blood. And that's what causes the destruction of said red blood cells. The first one I want to talk about is spherocytosis, hereditary spherocytosis. Here there's a problem in your membrane proteins. Your red blood cells usually look like this biconcave disc, and in the middle you have this area of pallor, this lightness to it. In hereditary spherocytosis, you don't have this biconcave disc. Instead, you have this sphere. That's where it gets its name. And you also don't have that central area of pallor, so it's just all red. Very, very classic. The membrane proteins that are defective are things like your spectrin, your ancrin, and band 3.1. I've seen questions where they just show this spherocyte, and then they might ask you what membrane protein is effective, and then through multiple choices you have to find which one is on there. Okay. You diagnose it with the osmotic fragility test. What the heck is that? You take your red blood cells, put it in a hypotonic solution. Because the membrane is so messed up, it can't handle that hypotonic solution, and it'll lyse. So lyse, and that is a positive test. Spherocytes itself isn't too big of a problem. What happens, however, is that your spleen will see that and say that's not normal and destroy it. And you can get really severe anemia that way. So if it's severe, you can do a splenectomy to remove the source of destruction. On the same vein, I want to talk about elliptocytosis. This is another defect in membrane proteins, spectrin. And instead of band 3.1, you have band 4.1. And this makes, judging by the name, these elliptocytes. Same deal, splenectomy if it's severe. The elliptocytes is a dead giveaway. Moving on. The next one I want to talk about is paroxysmal nocturnal hemoglobinuria. Paroxysmal means sudden attack. So you get a sudden attack of hemoglobinuria at night. That is it in a nutshell. What causes this? Well, your red blood cells have these surface membrane proteins that tell complements, hey, we're friends, don't attack us. And your complements leave it alone. If, however, those surface proteins are mutated in any way, shape, or form, then your complements will attack your red blood cells and cause it to lyse and get destroyed. The main proteins that you need to know is glycosyl phosphatidylinositol, or GPI. And this anchors these CD proteins, CD55, also known as decay accelerating factor, and CD59, also known as protectin. That's a fair name. Just as you memorize that CD8 is associated with cytotoxic T cells, CD4 is associated with helper T cells, you're gonna need to memorize these. Yeah. So commit these to memory because they're very, very important. And if you don't have CPI to anchor these, or you're missing these outright, then complements will destroy your red blood cells, because CD55, aka decay accelerating factor, stops C3 convertase, which is the enzyme that helps convert complements to other types of complements. CD59, aka protectin, stops C9 and MAC formation. That's the attack complex. And if you don't have GPI or CD55 or CD59, then your red blood cells are susceptible. Now, why are they susceptible at night of all times? Your complements work best in an acidotic environment, because if you have infections or you have inflammation, you usually have this local acidosis. And at night, your respiratory rate slows down and you retain some CO2, so you have respiratory acidosis. And that's what precipitates the attack. And so you'll wake up, you'll feel fine, then you'll pee, and you'll realize your pee is red because it's hemoglobin in there, because your red blood cells were destroyed when you were sleeping. So red urine in the morning is a big giveaway. Other things you can do if you're not quite sure, you can do the sucrose test. That's a big one you should know, sucrose test. That's when you put the red blood cells in sucrose, and the red blood cells are just fragile and they'll just lyse, so they'll lyse. But to confirm and to definitively diagnose it, you do flow cytometry looking for these. Makes perfect sense. If these are absent, then you know for sure it's this. There's some complications to this. These patients, for whatever reason, are at an increased risk of AML, acute myeloid leukemia. They're also at a risk of increased thrombosis, whether it's between the hemolysis or the complement activation. There seems to be an increased risk of thrombosis, and this is actually one of the main ways they die. They have thrombosis, heart attacks, strokes, dural sinus thrombosis, etc. So thrombosis is a big one. Treatment usually revolves around kind of tapering down thrombosis or tempering thrombosis through aspirin, heparin, warfarin, etc. You can give a drug. This drug is called eculizumab, and this is a C5 inhibitor, so it blocks complements. Complements are, however, still necessary for things like immune response, so you're at an increased risk of infections, especially Neisseria infections. So that's a side effect you should know. And also, just for, I guess, general knowledge, there's a controversy about this drug because it costs about like $400,000 a year. So there's still, for all intents and purposes, this disorder doesn't really have a cure because this is out of the price range for most patients. There are a few more intrinsic causes I want to talk about, and the next few are going to be due to enzyme deficiencies. One of them is glucose 6-phosphate dehydrogenase deficiency. And this enzyme is seen in the HMP shunt. It's actually the first step, and it makes NADPH. And I won't go too far into it because that's more biochem. And if you've seen our biochem videos and you know what I'm talking about, I'll link the particular video in the description if you want to check it out. But NADPH helps this thing called glutathione neutralize free radicals. So glutathione, in its reduced state, we'll see free radicals like hydrogen peroxide, and it'll neutralize that, turn it into nice water, nice safe water. And it does that with the help of the enzyme glutathione peroxidase and selenium, which you should know. And so this reduced glutathione becomes oxidized glutathione. And oxidized glutathione can't neutralize radicals anymore. That's the problem. And so NADPH says, I'll help you out. I'll recycle you back to reduced glutathione so you can go out and neutralize more free radicals. So NADPH helps it out. NADPH turns itself into NADP with the help of the enzyme glutathione reductase and FAD, aka B2, the vitamin B2. And by doing that, you get a nice little loop and you're able to recycle glutathione. If you have a deficiency in this enzyme, then you don't make NADPH, then you don't recycle glutathione. And so your red blood cells are going to face a lot of oxidative stress that it can't deal with, and that causes it to be destroyed. This deficiency enzyme is seen more in the Mediterranean population and African population because they think it's protective against malaria. So if there's an infection like a malarial stress, then the red blood cells will lyse. Yeah. Patients that have this and don't have malaria, most of the times they're fine. They're usually normal. However, if they have stressors, then the red blood cells will start to lyse. Stressors include infections, like I just talked about, drugs. These include dapsone. That's an anti-leprosy drug. Anyone that has leprosy, they usually get a test to see if they have this just before they give dapsone because they're worried. You can actually have it from anti-malarial drugs. Isn't that ironic? You can have it through things like fava beans. Fava beans have an alkaloid that causes this. And before they realized it was due to a deficiency enzyme, way back before modern science, they just call it favism. They realized that every time they had fava beans, they would precipitate this attack and they would have episodic signs of G6PD deficiency. What are these episodic signs? So patients with this will have episodic signs because they're not always exposed to stressors. So episodic signs include things like hemoglobinuria and of course episodic anemia. Yeah, so episodic anemia is just kind of characteristic of these. And then next thing they'll probably ask you is what kind of stressors were they exposed to? And then you'll just have to look into their question stem to find out what they were. Or they might be jerks and ask you some sort of biochem question. So as long as you know this pathway, you should be all right. Or they might ask, how do we test for it? We can test for the enzyme activity. Here's the trick. You don't test for the enzyme activity when you're having an acute attack, because any red blood cell that is lacking this deficiency will be destroyed. So first off, your test isn't really going to be conclusive of anything. So you test afterwards. That's the trick. That is G6PD deficiency. Now there's another enzyme in your red blood cells that can cause it to lyse, and they like this because they want you to get confused with G6PD deficiency. And that enzyme is pyruvate kinase. Pyruvate kinase is an enzyme that makes ADP. So the mechanism by itself is already different. It has nothing to do with oxidative stress. Pyruvate kinase, pyruvate kinase makes ATP. And if you have a deficiency in this, then what do you think happens? You have a deficiency in ATP. And without ATP, your cell just dies. So yeah, that's what cells do without ATP. What's the dead giveaway? Well, you're not going to have episodic anemia. Your cells just die. So you're going to have jaundice and anemia from birth. Jaundice, anemia from birth. If you're still unsure, you can test for things like increased 2,3 BPG, which is made in your red blood cells. That's a more specific sign. Or you can just test out the enzyme activity outright. And because you're deficient in the enzyme activity will be decreased. Those are more specific signs. Last but not least, we are done with enzyme deficiency. I want to focus our talk on hemoglobin disorders. And I know what you're thinking. You're thinking we already talked about hemoglobin disorders. We talked about that in microcytic anemia. And you're right. However, you also have hemoglobin disorders in normocytic anemias. There's a big difference. One of them is this causes normocytic anemias. That should be a difference enough. So this causes normocytic anemias. And also when we talked about microcytic anemias, we were talking about something going wrong in the production of normal hemoglobin. In normocytic anemias, this is something going wrong and causing mutated hemoglobins. So mutated hemoglobins. That is the difference. And that's why we're talking about it here. But before I talk about that, I just want to recap what's the normal hemoglobin in adults. The majority is HbA1. This makes about 97%. We said that was 2 alpha, 2 beta. Whoops. And then we have our normal variant, HbA2, which makes up about 2%. That's 2 alpha, 2 delta, and then finally HbF, which makes up the last 1%, 2 alpha, 2 gamma. Just keep that in mind. Let's talk about our mutated hemoglobin. The first one is Hemoglobin C. That's a funky one. This is due to a mutation in beta chain at the position 6. So I'll write 6th position. And at the 6th position, you have normally glutamic acid, also known as glutamate. However, in hemoglobin C, this glutamic acid is changed for something. It's changed for lysine. What type of mutation is that? Can you remind me? That's a missense mutation. I've seen questions like that. It's an easy way to get people, kind of catch people off guard. Yeah, you'll think you're doing a heme question and they'll throw off a genetic question. So that's a missense mutation where you're changing one amino acid for another, or one codon for another. So glutamic acid to lysine, and when you make that, you make hemoglobin C. And if you're heterozygous for this disorder, it's actually not a problem at all. But if you're homozygous, then your beta chain is disrupted. So what uses beta chains? It'd be your HbA1. So HbA1 will be decreased, and instead you're going to have this funky HBC. And HBC is very, very insoluble. It will start to precipitate out. It actually forms this crystal. Kind of cool looking, very pathognomonic. That's HBC. It's seen more commonly in Mediterraneans and Africans. Can you take a wild guess why? Just take a gander. I won't even mention Hawaii. You should be able to figure it out. The next one is the big one, and that's hemoglobin S, also known as sickle cell anemia. In sickle cell, it's the same thing. Problem with your beta chain. Heck, even same position, 6th position. And in the 6th position, you have glutamic acid, aka glutamate. And here, instead of turning into lysine, you turn it into valine. And by turning it into valine, instead of going to C, you go to S. And you make these sickles, these sickle red blood cells. And your blood cells can look normal. And then if they're exposed to things like decreased oxygen, they can sickle. So sickling increases if you have decreased oxygen, or increased PCO2, or decreased pH, or acidosis, increased 2,3 BPG, like anything that basically says you need oxygen. Yeah, they can throw it any different way. They can write it any different ways, but it just means if you need oxygen, it can cause sickling. If you have the trait, if you're recessive and you have the trait, then it's not a problem. You don't even see sickles on your blood. But if you're low on oxygen, or if you're at a certain, at a body part that's low on oxygen, like your renal medulla, then it can cause sickling. So trait, usually no sickling, but places like your renal medulla can induce sickling. And one of the signs is just a painless, very, very minute hematuria. That's sickle cell trait, that's heterozygous. If you're homozygous, then you have the disease proper. So we'll just call it the sickle cell disease. And you will see sickling in your blood, regardless of oxygen content. It will get worse when you have low oxygen, but you're gonna see sickles no matter what. How do you diagnose this? Well, you first screen it with something called metabisulfite, and that will cause sickling if you have sickle cell. However, that doesn't tell you whether you have trait or sickle cell disease, so you follow that up with electrophoresis. So all right, follow with electrophoresis. And in the trait, you might have slightly decreased HbA1 because that needs beta chain and you have a mutation beta chain. And you might have slightly increased HbS, very slight. If you have the disease proper, then you're not gonna have any HbA1. And HbS is gonna be through the roof. That's how you diagnose it. What are the clinical signs of sickle cell disease? In sickle cell disease, those sickled red blood cells will basically clump together and cause vaso-occlusion. It can happen in your bone. So you get these really painful bony crises, so your fingers can hurt, your legs can hurt. You can have avascular necrosis of your hip or your femur. So I'll just say bone. You can have vaso-occlusion of your pulmonary circulation. You can have that's what we call that acute chest. So you have acute chest pain, shortness of breath. I would say acute chest. And that's actually the most common way adults die. You also have sickling and occlusion of your spleen. So your spleen will start to sickle, start to enlarge before finally it gets infarcted and it starts to shrink. It becomes about like the size of a quarter. We call that autosplenectomy. And when you lose your spleen, you're predisposed to a certain type of bacteria. That's encapsulated bacteria. Your spleen is great at taking apart encapsulated bacteria. So if you lose your spleen, you're at increased risk of encapsulated bacteria. The big ones is things like H flu and strep pneumonia, so you have to make sure they're vaccinated. Otherwise, they're gonna get sepsis from that, like almost guaranteed. Also, salmonella is encapsulated. Salmonella causes osteomyelitis in sickle cell patients. When you see osteomyelitis, you're always thinking of Staph aureus, but if the patient comes in and has a history of sickle cell, or they might just say the patient is black and has past history of like bone pain, then the patient has salmonella-induced osteomyelitis because it's encapsulated, and this is more likely. And lastly, you can have extramedullary hematopoiesis, really severe ones. We talked about the really severe type in beta thalassemia where you had, the fuzzy skull and the chipmunk cheeks. This is, I think, the only other place you see it. You can see the fuzzy skull, the chipmunk cheek in both beta thal and sickle cell anemia. How do you treat it? Treatment. If the patient has an acute problem, you give them oxygen to try and reduce that sickling. You give them pain meds. You hydrate them. So you're basically trying to reduce that sickling in the acute setting. In the more chronic form, you give them hydroxyurea, Why do you give them that? Hydroxyurea increases hemoglobin F. Kind of like the only functional one we have other than HbA2. And the mechanism you don't need to know is quite complex, but increasing hemoglobin F is what it does. And in fact, when you're an infant, if you have sickle cell disease, you're protected for like, I don't know how many months, because you have increased hemoglobin F. However, when hemoglobin F starts to decrease, then the sickle crisis start to be apparent. That is the treatment of sickle cell. And that is your normocytic anemias. Hope you enjoyed the video. In our next video, we're going to talk about macrocytic anemias. Thanks.